Fluid administration is probably the most important element of resuscitation of patients with shock or patients with hemodynamic instability.
In fact, there are two problems. The first one is that all patients do not respond to fluid administration by a significant increase in cardiac output. All patients are not fluid responsive.
And we also know that giving fluid to patients who are not fluid responsive is at risk of fluid overload, pulmonary edema or edema of any other organs, and finally could result in a poor outcome.
So in order to predict fluid responsiveness, several tests have been developed, and passive leg raising is one of these tests. The principle of the test is that it will induce a preload challenge by transferring some venous blood from the legs but also from the abdominal compartment toward the cardiac cavities.
And this test is interesting because it acts like a preload challenge without giving any drop of fluid. It consists of increasing preload and to see if the patient increases the cardiac output or the stroke volume in response to this preload challenge.
And the advantage of the test is that it can be used in instances when other tests cannot be used, for instance, pulse pressure or stroke volume variations, especially in case of spontaneous breathing activity, in case of cardiac arrhythmias, and in case of ERDS with low tidal volume and low lung compliance.
And how to do in practice? In fact, passive leg raising is a postural maneuver consisting in moving the bed of the patient in order to create a preload challenge. What to do? We have to start from an initial position where the head and the trunk are already elevated at 30 to 45 degrees. This is the natural position of the patient in the ICU. And then we have to elevate the legs by automatic elevation from the bed in order to have the trunk and the head horizontal and the legs elevated at 30 to 45 degrees. And this maneuver is able to mobilize venous blood from the legs and from the abdominal compartment towards the intrathoracic compartment. This creates a preload challenge. And what we need is to follow the changes in cardiac output, and for this we need a real-time cardiac output monitor. And the patient would be considered as preload responsive if this maneuver, passive leg raising, is able to increase cardiac output or stroke volume by more than 10%. And in this condition, we can consider that this patient can be eligible for further fluid administration.
The passive leg raising is quite easy to perform, but there are some rules that must be respected. First, the test must be started from the semi-recumbent position at 30 or 45 degrees. The second rule is that the test must be performed not by moving the patient or by moving the feet of the patient, but by using the automatic motion of the bed. The third rule is that the effects of the test must be assessed by a direct measurement of cardiac output, not by blood pressure because it is less precise. Fourth, the measurement of cardiac output must be precise, and it must be a real-time monitoring of cardiac output that's able to show changes in cardiac output from second to second. And fifth, after performing the passive leg raising test, the patient must be moved back to the semi-recumbent position just to check that the value of cardiac output decreases back to its initial position. And finally, if cardiac output has increased by more than 10% during the passive leg raising, then the patient can be considered for volume expansion, being sure that cardiac output will increase with fluid administration.